Hi, everyone. Welcome. Thank you for joining us. I know we're a little bit late, but this is going to be well worth your wait. Thank you for joining us for a session of our Collaborative Partners mini-series. This series of 45-minute online sessions is specifically designed to offer a look at the latest initiatives of the OVOHT without requiring a significant time commitment from our busy partners and participants. So thanks again. I'm Crane Kelly. I'm the Chief Administrative Officer here at the County of Renfrew, and I co-chair the Health Human Resource Organizational Group along with my friend Jana Hodson from Deep River. We've tailored today's 45-minute online session to deepen our collective understanding of the challenges and opportunities of health human resources in our OHT. Understanding that there is a demand for more healthcare professionals in every community across Ontario to address the increasing needs of diverse populations. So today, and I'm happy to have everyone here because we're going to dive into some of the data, take a look at the labor landscape across the Ottawa Valley, and then take time for some of your questions. So first, I'd like to share our land acknowledgement. The Ottawa Valley Ontario Health Team acknowledges the land on which we operate has been inhabited by Indigenous peoples from the beginning. As settlers, we're grateful for the opportunity to work here, and we thank all of the generations of people who have taken care of this land for thousands of years. I'm coming to you this morning from Renfrew County in Pembroke, and speaking with many of you in the Ottawa Valley, which we acknowledge as the traditional territories of the Algonquin and Anishinaabe. We recognize and deeply appreciate their historic connection to this land. We also recognize the contributions that Métis, Inuit, and other Indigenous peoples have made, both in shaping and strengthening this community, as well as our province and our country. As settlers, this recognition of the contributions and historical significance of Indigenous peoples must also be clearly and overtly connected to our collective commitment to make the promise and the challenge of truth and reconciliation real in our communities and to bring justice to missing and murdered Indigenous women and girls across our country. So now I'd like to introduce you to our presenters. Susan Fullerton is the transformation consultant with the Champlain Community Support Network. Hello, Susan. And right after Susan, Allison Donnelly is the coordinator of the Bachelor of Science in Nursing at Algonquin College. So good morning, Susan and Allison.
Thank you. I always find 10 minutes is really not enough time. I'm not going to go through all the information on these slides. These are more for information. So if Claire wants to send them out, she can. And Claire, you're going to switch the slides for me, or can I switch my own slides?
I'll switch them for you.
Okay. So for those of you that don't know me, I'm a project officer with the Labor Market Group of Renfrew and Lanark County, which is funded by the Ministry of Labor, Immigration, Training and Skills Development, but it's administered by Algonquin College. And basically what we do is we collect labor market data specifically in Lanark, Renfrew, and then we use that information to drive workforce development. So my job was to just read thoroughly through the gap analysis and just demonstrate that how this report aligns to what we're seeing in the rest of the labor market in the area. And so this is really a good news, bad news story. So after reading Susan's report, which was great, the good news is I was really pleasantly happy to see that it aligns perfectly with what we are seeing, because that's what we do all day, every day, is analyze the labor market. Bad news story, obviously, is that we are facing labor shortages and the gaps in healthcare, which she'll tell you about in a moment. So I've just made a slide here just to demonstrate some of the key themes that was brought up by the report that align with a lot of the work and the data that we've collected. And I encourage you, if you have questions, I'd prefer to answer specific questions, so just feel free to chime in. The first three themes that we see here, labor shortages driven by demographic change, local workforce missing key skills training, and then youth out migration. These are all labor market issues that Renfrew County and the Ottawa Valley have been seeing for many, many years. So that's not a huge surprise, although especially with this huge demographic shift, we are seeing that shift accelerated, which I'll talk about in a moment. And then the next thing is, Susan will probably talk to you a little bit more about how, especially people that require registered occupations, so nurses, for example, need to be registered. We're really missing those higher up masters people, and youth out migration. Because of my work is connected to Algonquin College, I thought that everyone in this group would be really happy to hear. I just got some news yesterday that the Algonquin College Pembroke RPN program is waitlisted. So that's wonderful news. There's
Great news, great
60,
news.
yeah, 60 RPNs, and it's waitlisted, so that's great. And we're also really happy to see a practical nursing program being very successful in Lanark County as well. So hopefully we're going to be able to start to get those people trained in our area. And then the last four that we have here, community factors that limit emigration and immigration. When I say community factors, I'm talking about some of the things that you'll hear repeated in the report about housing, rising cost of living, difficulties with transportation in our area, increased number of retirements, mobility, and demand for flexible work options. Those last four issues in the labor market, it's very interesting because these have really just happened in the last 2-3 years. I'll ask you to switch the slide, please. I'm not going to talk too much about this slide. This is for your own information, but just to give more data about demonstrating this demographic shift, there is a portion of our population that is getting older, and people might be surprised to hear that in our area, over 48% of our population is over the age of 50. But that's exacerbated by low birth rate and these high retirements. And you can see here I've put the vacancy rate across Canada, which is 3%. And you want to remember that because Susan will tell you a little bit more about the vacancy rates in specific positions that she found in her report. Next slide, please. So we do a very large survey every year where we target employers. This year we got over 100 respondents. And so I just pulled out a few of the data points that really align with exactly what the gap analysis had already mentioned. So the employers that are participating in this survey are diverse. We've had manufacturers, we've had trades, public service, small business, food service. So we're really getting a broad section of the community. And you'll see here that over 73% of employers have had difficulty hiring in the last year. So we're not alone. We're all experiencing this. But what I was really surprised to see was this 39% of employers had retirements in the last year. So just like's happening in healthcare is happening in other sectors where the amount of people retiring is increasing and how quickly they're retiring is increasing. Go ahead if you have a question, just chime in. I've only got 10 minutes. I had mentioned in my previous slide about mobility. We are seeing increasing mobility in that people are moving jobs more frequently. There's many reasons for this, but a lot of the times it has to do with cost of living and that work flexibility. We've demonstrated that 50% of organizations lost employees to a competing employer in the last year. And then finally, 29% hired a newcomer in the last year. To me, I'd like to see that number increase, but I'm sure that it has increased over the last few years. Next slide, please. So along with our surveys and our data collection, we do community consultations. where we've gone across the regions. So we visited this year Arnprior, Pembroke, Perth. We had like 4 or 5 consultations. And so what I've done here is I've just pulled out themes of what the community has been saying. And these are not the opinions of Labor Market Group or the Ontario government. This is actual information, labor market information that people have told us about what employers are experiencing in the labor market. And you will see in a few moments when Susan shows you her report that this aligns exactly with many of what the other people have said. Labor shortages, increasing burnout, more mentorship is needed. We have high rates of youth out migration and immigration. We're struggling with daycare, finding daycare, those community factors that I already mentioned, and an increased demand for flexibility in the workplace. Next slide, please. So those are all our challenges, but what our community has been really great is coming up with some really incredible solutions. And I think that's really what's most important for this conversation. I think that the problem in Ottawa Valley is defined, and that this HHR gap analysis report really does a good job to demonstrate the challenges. And so now we need to find the solutions that are actionable and accessible. So we really want to increase youth retention and attraction. So keeping our youth here, that's part of that homegrown, grow your own idea. Community factors is one of the most difficult ones because as an employer, it's really hard to you can't do anything about the cost of living. However, we have seen over and over again reports of more and more partnerships. So increased numbers of private and public partnerships to support housing and transportation. And what I think we are likely to see in the next 2 years is more partnerships between municipal governments and service organizations. There have been 2 big transportation studies in Pembroke and in Arnprior about the feasibility of having public transportation, and it's really hard to get the funding that they need. And so I think a private partnership is likely. As I mentioned before, we do have reports in the community that flexible work is increasing. So you see that in remote work, hybrid work. Sometimes these organizations are creating parent shifts, job sharing or flexible work arrangements. And then what's always beautiful and wonderful to see is the work in our area, immigration and retention strategies. So Lanark County has a new immigration retention strategy coordinator, and the wonderful work of local immigration partnership, as well as robust marketing campaigns from both counties promoting a rural lifestyle. All right, last slide. This is just for your information. I'll go to the next slide. So this always creates lots more questions about the data. And so I would like you to contact us if you want specific data about the healthcare positions. What we really need, if you want specific data, is we need a specific geographical area. And we also need the specific name of the occupations that you want included. Just because, it's different if we're asking for the numbers for nursing versus practical nurses versus RPNs. So for us to gather that data for you. But I do encourage you to reach out. All of our services complimentary. Any data you want, you just ask us. And then depending how much you need, that will depend how long we can get it back to you. But I also want to mention, if you navigate to our website, we do have job tools for employers to use where you can pull your own job market data. You don't have to wait for us. It's available to you 24/7, and you can get things like how many nurses, how many RPNs, how much they're making, et cetera, et cetera. So I'll leave it there because I'm already past my time. But thank you, and please let me know if you have any questions.
Thanks, Alison. Why don't we leave the questions for a moment? We'll hear from Susan now that we've given her voice back. And I will note that mentorship piece though, Alison, is really interesting. That was a you kind of hear the other pieces, but we're starting to hear as employers that the new employees would like mentorship or better management or better supervising. Their supervisors have better skills to allow them to manage. So interesting, good takeaway.
Yes, this is just like a little snapshot. So if that is a portion that the group is interested in, I can come back with more of the ideas that the community had mentioned specifically about mentorship.
Excellent. Thanks, Alison. So with that, Susan, welcome.
Hi, hello everyone. Thank you. Sorry about all the technical issues there, but we're on track now. I will probably be skipping some slides because 15 minutes was tight for me anyway, and under that. So if I talk too fast, just tell me because I will, knowing I have a lot to get through. So to start with, gap analysis that I did, a gap analysis in general looks at the current state, what your desired future state is, and an analysis of that space in between to kind of inform how significant is the problem or how big is the gap. And in this case, we also really use this opportunity to try to better understand the context. So is that a question or just a microphone? I think just a microphone.
Yeah, just a microphone. Yeah, you're good.
Yeah. Okay. So the ask when I first got this was to look at a gap analysis of the healthcare workforce across the OVOHT geography and to identify, in order to identify and address labor force shortages in terms of numbers, types of healthcare professionals required to enhance quality of healthcare services. This is a lofty goal. So this purpose speaks to the broader HHR work. So we did spend some time scaling down the project, recognizing that there is a need for a stepped approach when we're working with data that is a moving target. So any of this point in time data, and I'm really glad to hear from you, Alison, that there is access to this data on a regular basis, which is fantastic, because this was collected in December, already probably out of date. These things move on a day-to-day basis. So that's fantastic and just gives you a bit of context to the limitations of the information that we have here. We also focused the scope a little bit, limited the definition of healthcare workforce because it just wasn't possible to do it all at once and felt the data would be more meaningful if we target specific groups. So the updated expected outcomes are that I would provide a report, which is really functioning more as a reference document than a conclusive, these are solutions. It's not that document, it is a reference document. And the information was used to identify the workforce needs to meet the current structures and service agreements. Those will be shown in the numbers and the data charts that I'll show you in the next slides. It was also going to provide insight into the desired future state because that really isn't defined yet. We don't know what that's going to look like. For the purposes of the numbers that you're going to see, that's to fill those current agreements, but that's not really the end future state, and I will talk about that. And the last piece is really to talk about key elements to consider and analyze to inform those next steps. So we really are making sure that when we are developing an HHR plan, it's responsive to the community needs. So who is engaged in this? We looked at a few different sectors. So hospital, long-term care, and community. Can pop ahead already. And healthcare providers. These were the ones that we collected data from in the survey. The vast majority of the workforce is in the nursing and personal support worker areas. So that's really where we focus. They're actually 80% of the workforce. So that's where most of our data is. But we did collect other data, and there's a whole bunch of healthcare workers that are not included in this that we really need to look at. Most of them within the community, and it's such a huge opportunity and ability to leverage all of these other workers that are there. So we want to capture that data as well, but it is not included in this. Next slide. For the survey itself, we had 40 individual responses, and 90% of those, as you can see in the graphic there, are direct health service providers. So really from the people who are providing the day-to-day service. We had representation from 64% of the member agencies in the OVOHT, just to give you a bit of context. And again, that was collected in December. Next. The consultation piece was done in February. That's where we got additional qualitative data and really tried to understand what some of the causes were for these issues and what we might look at moving forward. There were 3 consultation group sessions and 4 individual interviews that took place. We had 20 individuals who engaged in this part of the consultation, representing 16 of the member organizations. So those are the people that we targeted. Whose data is actually represented in here? Who did we get data sets from? These are the people that we got those from. So community service providers, home community care support services provided qualitative data, not quantitative, and that's pretty significant for the community piece. So just so you're aware of that. Community support services and paramedics provided data sets. Long-term care, all the long-term care homes within this OHT, which is great, all the hospitals within the OHT, so that data is very comprehensive in here. Lots of engagement from community health, so primary care groups, although primary care physicians were out of scope, there was lots of engagement from that group, so from community health centers, family health teams, family health centers, which was fantastic. We had great engagement from mental health and addictions, covered both children's and senior services, and the municipality was engaged both in the survey and in the consultation. So what were the actual findings? So overall, we found a regional vacancy of 7%. And if you recall what Allison was saying, it was about 3% average across, was it across province or the country? Can't remember. It's okay.
Across the country.
Thank you, across the country. So you're looking at 7%, which actually sounded low to me when I hear the impact that it's actually having on health outcomes. So this is average if you're looking at all of the different disciplines that you see listed there on the right-hand side. I also broke down this data and analyzed it based on sector and practice environment, based on specific discipline and professional designation. And then I did a little bit on geography as well, which we probably won't get to today, but all of it is in the report if you want to get those details. You're doing a great job of moving it exactly what I was going to say to move it. Okay, so here we're looking at it divided by sector. If you look at the pie chart, it really makes it look like that the blue, that community sector, oh, it's not such a big issue there. It's only 18% of our vacancy rate. But if you look over at the bar graphs that really give you context for each of the sectors, you see those vacancy rates for all of the practice settings are all within 2% of each other. So what we're seeing in this HHR challenge right now is really a cross-sectoral issue, and we're seeing consistency across all sectors in this particular region, which is a really important thing to look at. I find sometimes when graphics are presented, it's easy to just look at it and make a conclusion in your mind, so we really have to be careful about how we're presenting them. Next slide. So this one is looking at the findings by discipline. This first slide here is on the nursing disciplines. The next one will cover allied health. So with the nursing discipline, again, not surprising with them taking up 86% of the workforce, it also was a 7% vacancy rate on average. But breaking this down by the different disciplines, so registered nurses, registered practical nurses, nurse practitioners, and PSWs I've included in here just because they work so closely together. You see that that range is a little bit broader, goes between 5 and 10%. So that's was interesting to look at and to look at where those differences are. Again, when you look at the actual report, I have percentages and numbers in here as well. So while it looks like there's a big gap in nurse practitioners and there is an 8% vacancy, it actually is only representative of 2 vacant positions. So it's really important to look at all the data in the report. This is really just high-level overview. Next slide. So this is looking now at the allied health or the non-nursing professions. When we looked at all 5 of the allied health or the other professions that we looked at in here, the vacancy rate was 7%. Then I looked at, pulled out just the regulated health professionals, and that vacancy rate jumped from 7% to 12%. What you're seeing in front of you is even further filtering, where we're looking at regulated health professionals that require a minimum of a master's degree, because that included PT, OT, and social work. And that vacancy rate bumped up again to 13%. And the range you see here is between 12 and 16. So a really big gap within this area. As I mentioned earlier, though, with home and community care or Ontario Health at Home now, we really need to gather more data from them so that we have a fulsome picture. And that community piece should be the focus, in my opinion, should be the focus of the next area that we look at to really get a comprehensive picture. Hey, overall trends, which was a really interesting find, and it was consistent across everything, that the vacancy rates increased as the level of education and training increased. I'm not talking about the individual person's level of education and training, because that's going to vary a lot. I'm looking at minimum standards in order to practice within a particular discipline. So we start looking at those that require college training, those that require college training and are members of regulated profession, bachelor's and regulated, master's and regulated, and the last one is the MDs. And you see a consistent increase in the percentage of vacancies. It is harder to fill positions for people where the training takes longer, where the expectations for salary are higher, and we can't always fit that in. The expectations of the providers are high as well, and the quality of service they provide, the number of people they see, and that's hard in a rural area as well. And there's not always financial compensation to make up for that and allow them to do the work they want to do. I do just want to say on this slide, though, just so people don't take it as a, hey, this is a hard, fast rule, that 20% for the MDs, that is an estimate based on my discussions with Richard Johnson, who's really doing this work. I really looked at the approximate population of the area, the average practice size for primary care physicians and nurse practitioners, actually, and unattached patient numbers to really get that 20%. So that's where that came from. It's an estimate. The others are numbers that came directly from our data. Okay, so from the qualitative piece, and how much time do I have? 7 minutes at most. Okay.
You're good, Susan, that's fine.
So from the consultation piece and also in the survey, we talked a bit about this. The greatest challenges facing HHR within this region were identified as recruitment to the region, which Alison talked about, and it's really consistent with what they're finding. Changing demographics, which she also mentioned, affecting not only the workforce, but also the people that are being served within the community, which of course includes the workers as well. And then the availability of skilled professionals. And I think that that trend that we were seeing in the chart about the different levels of education is really telling there and can really help to do some strategic planning around HHR. I'm sorry, this came back on. I had everything muted and now it's on there. Okay. So we can go to the next slide. In the report, by the way, there's a lot more detail about all of these different things. So if I'm really just glossing over something, there are details. If you don't have the report, we can get you access to it, and it does have a lot of detail. So in terms of what were the actual identified gaps based on the numbers and the objective data that we collected, there was the 7% vacancy rate across the full region, which is the gap between available full-time equivalents and filled full-time equivalents. And there were also identified gaps in coverage capacity, or what somebody called bench depth across the region. So being able to fill positions when somebody's sick, when somebody's not there, when there's, and they end up pulling people from other positions to fill. And this is a problem with efficiency, with getting work done, with job satisfaction. It has impact everywhere. So those were the main two gaps that came from the actual data, but these are just numbers and they really don't tell the whole story. Really important that we do a needs assessment to understand the impact of the vacancy rate on health outcomes as opposed to just the vacancy rate on its own. The future state isn't just about meeting those service targets, but it's about having a positive impact on health outcomes. And that will improve experience both for patients and for providers. So can help in a lot of different areas. The report that I have also does have details on all of those things and details information about the variability between professions, type of service, practice environment. I've also identified some of the significant outliers as priority areas, so those who were significantly above that 7%. Okay, so these are gaps that weren't necessarily shown in the numbers, but were so consistent in the qualitative feedback we got that we know that there are gaps out there, and we need to look at these with as part of that overall lens when we're considering next steps. So overall employee and labor pool depletion was brought up by everyone. Service gap by many people, sorry, service gaps related to access and navigation, and the unmet and growing needs of an aging population, which has been talked about quite a bit today. System and process gaps were another piece. So with this, they were talking about the current structures that we have within healthcare and how that does or doesn't meet the expectations of a new generation of workers. They're, like Alison was talking about, the need for flexibility in jobs and the mentorship. Mentorship was brought up quite a bit, actually. And where I'm talking here about beyond recruitment and retention, retirement was something that was brought up as having intentional retirement that could build mentorship into it. So employees who are ready to be moving on can be mentoring the new ones coming in. So just different ways of looking at things. And we know that we need innovative approaches, not only to look at how healthcare is delivered, but by whom. It may not look the same way that it does right now. Next slide. Some of the trends that we were seeing, these trends were used to identify patterns and highlight opportunities and barriers, again, detailed within the report. But just to give you the highlights, some of the main trends we were seeing were in the professional training, community-based services as an opportunity for growth, building strength from within as that homegrown approach, which has opportunities all across the region. So it can be done regionally with longer term outcomes, and it can be done locally for specific issues. Scope and skills-based needs assessments, retention factors, focusing really on provider experience measures, getting people in, they're looking more at the provider satisfaction, what are the salaries, what are the benefits, but once they're in there and keeping them, it's about the experience. Are they getting what they expected to get as a worker? Are they supported? Those types of things. And a positive trend that we're seeing is that there is growing stabilization. And I think this is a wonderful opportunity for shared learning across the region. We've seen some stability and had stability reported in terms of some hospital staffing, introduction of virtual models of care. There's strength reported in the care coordinator pool with home care, and some really innovative partnerships that have happened across the region and have improved this landscape. So lots of opportunity for learning. I feel like I'm just really glossing over, but I do want to get through some things here. I'm going to leave the community bit, but go back and have a look at it. It's really just demonstrating that there are really distinct communities within this area, and it's very challenging to look at it as a region as a whole because there's so much variability within there. So the types of things that the OHT is going to look at, which are regional, may be different than what your local communities look at, but they can absolutely work in tandem. Okay, the 3 improvement strategy themes that came out, these emerged mostly from the consultation, but really consistently with very different groups of people, which was interesting. 3 top strategies that people felt would be valuable within here were regional recruitment. So we say bringing people to the region, strengthening our communities, and building that passion for rural life. Sustainable solutions, really based around understanding the unique patterns and cultures of the communities within the OVOHT. So that chart that I just skipped over, that type of thing, understanding what's typical within that area, what the issues are in each of the smaller communities will help you build something that's sustainable. The regional work itself, working more toward longer term measures of success, things like population health outcomes and provider experience. And if you're looking for a place to start on that, the HSPN, the Health System Performance Network, put out in January the most recent improvement indicator reports, which really look at where each of the OHTs sits in comparison to the OHTs across the province. So really interesting document, and really helps to guide things if you're sort of starting from really broad and needing to focus work moving forward. And then thirdly, but maybe most importantly, are the innovative approaches that are needed to make improvements. So not inventing something brand new, but finding new and creative ways to work to achieve our healthcare goals for the communities, and not only for the future, but also within the context of current funding and regulatory structures. And I think some of that work has been done within this region. And I feel that the OVHT is actually ahead of other areas in some of their innovative approaches. So there's lots to build on here. I'm not going to go over this, and I actually didn't even put the details on the slide, but I do have a modified SWOT that also can be used for any of the HHR working groups moving forward to kind of look at what we can pull from, where we have strengths, what weaknesses we need to cover for, and then externally what opportunities and threats are there and how we can look at them. So really quick, next slide. Well, this is my last one. I talked really fast. Okay. So I did include a recommendations table that has quite a few details and breaks down these areas, but I did organize the recommendations into these 5 areas. So none of them will be new to you: recruitment and retention, funding, models of care, infrastructure, and education and training. I think these 5 together really provide a very robust picture of what the HHR landscape is. I mean, you change something in any one of these, then the types, the numbers and types of professionals that you need, that moving target I talked about earlier, that will also change. And while work in these areas may be separate from the HHR table, they are inextricably connected, and they really do need to be looked at together. So every project needs to consider the others that are touching it. This assessment was really looking at gaps in staffing to meet current agreements and staffing models. I know I'm reiterating that, but it really is a limitation of what I was working on here. And there is definitely a need for further evaluation and broader needs assessment. So we really can identify what are the service gaps as opposed to just the gaps in professionals, and how do we prioritize target populations for service delivery. the last point there that I really feel it's important that this work includes an assessment of skill and service gaps to supplement the data that we have on professional gaps. So there I'm talking about professional discipline versus the actual work that's being done. What are the skills and services that are needed? Who can provide those services? So that's looking at scope and training, that type of thing. And then what is the most efficient and effective way to fill that gap? We may not be having the same people doing the same jobs, but if we can look at it in a creative way, we should be able to move forward in terms of the health outcomes. So that was my whirlwind tour of what's what's in the report. It really is very detailed if you look through the report itself, and hopefully the categories will help you to jump to the sections that are of most interest to you because it is long. I mean, really, I could say we're looking at the current level of vacancy to filling gaps, 7%, and that could be the whole presentation. But as you see, it's so not the whole story. And I think all of that additional information is really what we need to make a change and to inform the projects moving forward. I have put in a proposal to JMA actually just about some recommendations for next steps in terms of a needs assessment. I'm not sure what's happening in terms of pace with those things right now, but there are certainly lots of suggestions within the report as well that if people are in working groups or moving forward, I really hope that it is a valuable reference document for you. It does refer to other documents and reports that you can use as well.
Well done, Susan. Wow.
Woo.
Getting through that. No, really, really interesting. Yeah, so there was the HHR working group met yesterday, so we've got some action items coming out of that. It was discussed, so we'll definitely move that forward. Claire, I'll turn to you to moderate some questions, perhaps, if there are some questions.
Sure, yeah, absolutely. And again, apologies for the tech issues early on. I know we may have lost a few, but absolutely, if anyone has any questions.
They're absorbing it all. And if you haven't had a chance to read the report, if you haven't seen all of it, please reach out to Claire, and I'm sure she'll forward along, or JMA definitely will do so.
Absolutely. And on that note, Craig, that's right. That was kind of a bit of a whirlwind. So if after some of this has sunk in, if you do think of a question, please feel free to email. Be happy to answer. Oh, we've got Tina's got her hand raised. Go ahead, Tina.
Hello, everyone. I was just thinking about the regional approach to bringing people to the sector, and that's something we're in the community and social services sector, and so often are sort of competing for similar bodies in terms of positions. If there wasn't a regional approach that wanted to think broader than health, I know that our partners at our DS table would be interested in that, and if there's something that's already started that we could be a part of, we would want to be. So hope that you can keep that in consideration. But we did work with Native Education and Training Centers, and they did a video a couple years for us that highlighted not just the sector, but highlighted how great the valley is and the Ottawa River. And I don't think it really netted a huge applicant pool, but it is something we'd be interested in.
That's great, Tina. Yeah, I was also recognized the home care sector could weave in here too, through Sheila Dunn yesterday, who raised that. So no, really good point. We could definitely add that to it.
Thanks, Tina. Kelly, you've got your hand raised. Go ahead.
Yes, just segueing off of what Tina just said, oftentimes when you're hiring people to move to the area, you're hiring a family, right? Like you're bringing spouses and the other employers in the region could also benefit from those efforts as well, right? Partnering with some of the major employers could be helpful for the healthcare sector.
Big
I
time.
feel like the feedback that we got on that was what is definitely transferable to all other sectors. It's not just healthcare, the things you're talking about, like the daycare and having places even to gather in cultural centers and restaurants and things that bring and keep people in an area. I mean, you guys are wealthy in terms of outdoor activities and nature and some brilliant things that we don't have in the city that really can be marketed. But there's, those infrastructure pieces that are really needed as well, and transportation being one. And the more data we have from collective sectors, the better able we'll be to collect funding that doesn't have to be just for healthcare, and be a bit more creative about where it comes from.
Great, great. And then, sorry, V. Benoit, I'm so sorry, I don't know the first name. There was a hand raised. Oh, now it's gone. Maybe the questions evaporated.
I just talked too long, sorry.
No.
Oh, you can't unmute for some
Oh,
reason.
no. Oh, no.
One of these little things here, let's see. Okay, well, maybe she'll.
Can write the question, did you?
Yeah, perhaps write your question.
Just further to Kelly's comment, actually, in primary care, we notice it a lot. It's a great point of, you know, we recruit a physician, but then if you don't recruit the whole family, or if the partner doesn't have a suitable position in the area, they don't necessarily feel embedded in the community. And that can affect retention. Then you may get them here, but then they don't, if the rest of the family's unhappy, right, or doesn't feel settled or comfortable, then retaining that position, you know, it becomes more difficult. It's a great point.
That's exactly right. Or they may not actually move to the area. They might try to commute, right? Which
That's right.
doesn't really work out in the long term. Yeah.
There are some virtual things happening. Of course, Judy Hill in Petawawa is doing some new and innovative things with virtual healthcare. But that's also, that only goes so far, right? I mean, that only goes so far. But in terms of spousal employment, it may work, right, as we're seeing, but
It does a lot to help with access and temporarily with volumes, but I think you really want a connection to the community. It's so important to feel that connection, to be a part of it, to want to stay, and then for your kids to want to stay as well. So I think virtual absolutely has its place, and I don't want it to see it go away at all. But I think if we move to too much virtual, there's going to be that feeling of disconnection that we already feel as a society after COVID. And I think a learning from that is we can't isolate people for that long. We just can't.
Claire, are you able to see Vicky's question now, or yeah?
Yes, yeah. So Vicky's just put in, did you look at HHR shortages in French language services?
That's a great question. And I didn't have that as a specific factor within this, interestingly, because we do that all the time when we're working in Ottawa, and I didn't do that out here. But that is definitely something that we should be including in any future HHR work. You're absolutely right, because there are mandates around that, there are requirements, and we do need to look at that. So thank you for bringing that up.
Thanks, Vicky.
Allison, do you have data that includes language?
Yes. And so like what you could do theoretically is you could go onto the website and you could search. We would have to do the search for you to filter out specifically for French, but you could go on and search a position and see how many of the positions required French, as an example. That's something anyone could go on our website and do. So yeah, it'd be interesting to look into.
It's awesome.
I only really pulled there are so many different healthcare positions. So I only pulled for nurses, and I was really glad to see that the number that you would come up with was very close to what our number was. So it looks like all that's really aligned. So that's great. And then now we just have to look at everybody else.
Yes, yeah.
You
And
know,
there is some good data out there. And CIHI has data on many of the regulated professions too, because we're required to fill that out every year when we register. So hopefully we will have a really good data set to move forward with without having to pull it or like to create it each time. It's already there. You guys are doing that work. So we need to leverage that. We're not always good about doing that. Sometimes we reinvent the wheel when we don't need to. So it's great to know what's available and to see what's out there.
Tina's just got her hand raised. I'll let you go ahead.
Yeah, thanks. This is related, but somewhat unrelated. We're trying to host an event on June 5th from 8:30 to 10 in the morning. It's going to be a leadership spring mingle. We've just noticed in our sector that a lot of our partners' leadership bodies have changed. And so we're inviting CAOs and executive directors and other people in leadership roles to come together just for an hour and do a bit of a spring mingle and get to know who's who again. So we have a group list already that's going to be going out hopefully in the next couple days. And certainly the county and Chamber of Commerce and Labor Market Group and hospital and lots are represented on that already. But if you'd like to be on that list and included for an invite on that and be part of that, if you could just send me a quick email and I'll put my email in the group chat.
What's for
Thank you
lunch today in Spring Mingle?
It's breakfast. It's going to be 8:30 to 10. It's going to be coffee and croissants and maybe some fruit if we can afford it. And likely out at Best Western. Yes.
There you go. Perfect, Tina. That's great.
Is
invitation.
Ontario Health at Home going to be represented there? I think having their new care coordinators for the area would be great.
I am not the keeper of the list, but if you wouldn't mind putting that in the chat, I will take it back to
Sure.
our team who's developed it. Thank you. Or email me directly if you'd like.
Perfect. Thank you, Tina. Great invitation.
I'm not sure if anyone else has any other questions, but we're nearing 12 and we've taken up everyone's time. Everyone's been great to stay on.
Okay, well, thanks everyone. Thank you, Claire, for moderating that. Absolutely. And again, lots of great work happening. This is seems like the tip of the iceberg, Susan. I think we're gonna be engaged for quite some time learning some more data. And Allison, again, the tools that you provide are just incredible for the community. So really thank you to both for presenting today, and we look forward to more information. There's going to be a quick survey I think Claire's going to send out to everyone, just a bit of I'm not sure if you put it in the chat or just at least email it out, just some feedback, so that's great. And our next forum, I believe, is on June the 7th, so it doesn't compete with Tina's breakfast on the 5th, on the 7th, and that one is on people with lived experience, which is an ED Pathways to Community Services pilot, so even more information in the future. So again, thank you, everyone. Thank you for your patience, and hope to see you again soon.